France to come up and tell us about complications of the Nuss procedure. The Children's Hospital of the King's Daughters experiencing over 1,500 consecutive patients.
Good afternoon. I'd like to present to you today complications of the Nuss procedure in over 1,500 patients. I have no disclosures. Since Dr. Nuss's introduction of the procedure in 1997, this has become the operation of choice for repair of severe pectus excavatum, mostly as a function of numerous modifications that have been made from innovators like many of you sitting in a room today worldwide. Our group continues to monitor the procedure for optimal efficacy and safety. What I'll describe today is a retrospective review of 1,584 consecutive primary and redo Nuss procedures between 2000 and 2014. We've selected this population because they are representative of the current version of the procedure and incorporate fundamental modifications that have been made since initial introduction, including thoracoscopy, wired stabilizers, and three-point bar fixation. My goals will be to characterize the short and long-term complications, describe treatment plans and technical modifications that we have implemented, and also to summarize the lessons learned for complication prevention and increased safety. These are our complications listed here. The early complications occurred within the first 30 days post-op and include pneumothorax, pleural effusion, hemothorax, and cardiac perforation. All others are the long-term complications, and I will review them subsequently. Pneumothorax occurred either because of residual insufflated carbon dioxide that was not evacuated, lung trauma that typically would occur with pleural adhesion presence, or leaks in the system. And you'll see at the bottom there that one of the important things to do is to avoid spontaneous ventilation when the chest is open, because the chest will fill with additional air that subsequently needs to be evacuated. This is our evacuation procedure here using the scope and the insufflation tubing. Indications for thoracostomy were continuous bubbling during evacuation, witnessed injury to the lung parenchyma, or a moderate or large pneumothorax on the postoperative chest x-ray. Hemothorax occurred in 4 early patients and 5 late. There were no blood transfusions, and the late patients had a higher incidence of history of trauma. We do have 1 cardiac perforation in our group. It was a 15-year-old male with pectus excavatum and a Haller index of 4.95 with cardiac compression. Of note, the patient did have a past surgical history of ASD and VSD repair at the age of 3. At operation, the patient had 1 bar inserted with partial correction. Pericardial adhesions were present and made it difficult to tunnel for the second bar. The right ventricle was injured with the introducer. The patient subsequently had sternotomy with surgical repair by the cardiac surgeon on call. He had complete recovery with subsequent discharge home. The highest risk of cardiac perforation is in redo patients and those with deep sternums and stiff chest wall. Subsequent to this occurrence, we have changed our protocol and taken steps to prevent this from occurring again. The preventive steps include the use of thoracoscopy, right, left, or bilateral, during dissection to keep the pectoris introducer tip in view at all times. Utilize a 30 or 45 degree scope to optimize visualization. When placing multiple bars, create the superior tunnel first to elevate the lower sternum. There are multiple methods of direct sternal retraction that can be used now, or a subxiphoid approach can be employed. We also have an extra large introducer, which I'll show you, with a longer tip that's useful for deep sternal depressions. Additional safety measures for redos include having a sternal saw available in the operating room, typing and crossing for blood. If you do think you have an injury to the heart, it's important not to remove the introducer until you're prepared to put the patient on bypass or to repair that laceration. And also, we do have our cardiothoracic surgeon available for these cases. These are the introducers that we use. This is the extra large introducer that you would use for deep sternal depressions. And this is a representation of the tunneling technique This is the sternal depression, the beginning of the passage of the introducer, and you'll notice that the tip is visible at all times. This last picture is actually the tip advanced out the left chest cavity, and here you'll notice the correction of the sternal depression. Pectus bar displacement is the most significant complication from this procedure. The overall incidence in our series is 3.7%, and 2.6% of those patients have required revision. The definition of bar displacement is a bar shift greater than 15 degrees and evidence of recurrent depression on the external exam. These occurred 1 day to 2.5 years post-op, and if you look at the revision procedures that were undertaken, the most common is actually the addition of a second stabilizer. These are x-rays of bar displacements. The chest x-ray for these is typically diagnostic, and these patients present with a sudden onset of pain and a recurrence of their deformity. This is a patient who did not require intervention. This is a 15-degree shift present, but you'll notice on the external exam there is no change in the appearance of the repair. The utilization by multiple bar placements in our group over time has likely resulted in a decreased need for revision, and that is reflected here, which shows year by year our bar displacement rates. Several things to note here. The historic displacement rate in our group was 12.5%, which has now decreased significantly. The second is you'll notice this blip here in 2008 and 2009, and our group had actually done a trial of absorbable stabilizers during that time, which did not work out. And this is what resulted is we had an increase in our bar displacement rate, but overall the trend has been declining, and you'll notice that there is a decreased proportion of these patients in the red bars that have required revision in the later patients in our series. This slide also verifies the improvement in our bar displacement rate with changes in securing the bar. The prevention of bar displacement is multifactorial and relates to the correct bar length and contour, positioning the bar properly with the bar introduced at the lateral aspect of the pectus ridge, the bar placed under the deepest point of the pectus, and observing complete flattening of the sternum. I'll demonstrate to you our bar fixation practice, and also the activity restriction afterwards is important to minimize this. This is a picture of our 3-point fixation, which is lateral fixation on each side, one side typically with a stabilizer, and then pericostal sutures placed medially to attach the bar to the underlying rib. Wound infection was seen in our patients in 2 weeks to 2 years. There were 2 groups of patients, those that had either intact skin or disrupted skin or abscess that did not involve the bar, occurred in 1.4% of patients. The other group was deep infections with bar involvement, which occurred in 1.1%. The treatment for these patients, 20 of these patients had superficial infections which responded to antibiotics. Another 20 did require surgical drainage. The good news is that only 3 of these bars in the group required removal. They were all salvaged with antibiotics and incision and drainage. This demonstrates the spectrum of presentation of infection with just erythema, abscess, and granuloma. Our treatment for this complication was basically intravenous antibiotics, considered a bar allergy, drained and washed out as necessary, wound vac if we couldn't close, and the treatment was continued until normalization of lab data. Several of these patients required long-term suppressive antibiotics during the period of time, and our goal was to try to maintain that bar for 2 years to still gain the benefit of the sternal elevation and chest wall remodeling. If the antibiotics were not effective, those were patients considered for bar removal. The only really significant step that we added to the additional procedure that most of you would use for this procedure is we did start to use perioperative skin decontamination with 2% chlorhexidine, which did appear to have effects for improvement. Metal allergy is well recognized in other surgical specialties, and we have experienced it here. The presentation of metal allergy post-op really is rash, pain, maybe a low-grade fever, but you can also have associated symptomatic findings of pleural effusion, pericarditis, or even granuloma. In some cases, these folks will have chronic fatigue. We screen now for metal allergy preoperatively, and if we find positive testing, we will use titanium instead of stainless steel. Postoperatively, the patients are tested. They are started on antibiotics. Empirically, they are treated with prednisone bursts, and they again are treated until their labs normalize. If they don't improve, we will remove the bars. In some cases, as you'll see, we've replaced the bars with titanium at the same time. This is our incidence of bar allergy. You'll notice is very low. There were only 4 bars that were removed in this series. 2 patients just had bar removal, and 2 had bar removal and replacement. All others were successfully treated with steroid and antibiotics. Since 2011, we have started routine allergy testing, so that's part of the reason for the decreased incidence. This is an example of a patient with a bar allergy post-op who was treated medically to get him to 2 years successfully. Overcorrection occurred in 1.1% of our group. It was severe enough that in 0.25% that carinatum developed. The majority of those patients had Marfan's disease. How do you prevent this? There may not actually be a way to prevent it. Ways you can minimize is to use an acceptable bar length, use multiple bars rather than single bars to distribute the force better. We have graded the patients with overcorrection. Most of the minor overcorrections we observe. Moderate corrections, we may take the bars out earlier, brace, and severe overcorrection will need cartilage resection. Again, this is an example at 4 months post-op of what can occur in these patients that overcorrect. We have a recurrence rate of 0.7%. Let me go back here, sorry. And the majority of these have really occurred in our younger patients when the bar was removed prior to 2 to 3 years post-op. The subsequent treatment in this group, 3 had additional repairs, 5 were observed only, 2 lost to follow-up, and 1 patient is actually successfully being treated with a vacuum bell. This is a declining trend, and mostly because we're now operating on these patients at an average age of 14, and we're placing multiple bars. An example of a patient who recurred, this is a 6-year-old before repair. This is immediately post-op. The patient overcorrected and had his bars removed at 9 months. This is 6 years later, and this is his results after redo. Just for completeness, this is our unusual post-operative complications. And to summarize, the incidence of complications is declining, mostly employed to modifications that have been made to the procedure, and we still have potential areas for improvement with bar displacement and wound infection. Thank you for your attention.